All right, guys, we are here in the lab. My name is Ramana Naidu, as you can see on your screen. I feel like I'm on TV, like I'm doing news. This is awesome. With me is Kasim, one of our fellows, and we're going to do a whole DRG implant in 30 minutes. We might skip some steps, but we're going to get cooking here. So what we have is a patient who I did not preoperatively screen, but who says they have right knee pain after a total knee arthroplasty. And as you guys know, the dermatomes that are involved in the knee generally are L3 plus or minus L4, L2, just depends on where the pain is, medial, lateral, etc. But generally for knees, L3 is the primary, and then L4 potentially, and if there's more proximal issue, L2. So those are really your sweet spots when it comes to DRG stimulation. What we've done here in this cadaver is line up the superior end plate of L3, because that's going to be our target pedicle. And as you can see here, I have a straw tunneling tool. I don't know which camera I'm looking at. This is my straw tunneling tool, which you'd use for SCS. I use as a straight rule. So what I'll do is I'll just use fluoro here to identify that L3 pedicle, as you can see here. And then I'll shift down just a little bit, so I'm going through the interlaminar space. So do you guys see that? Target pedicle through the midline epidural space, and then I'll draw a line. And as I mentioned, where I start depends on how big the patient is. And you really can't see on your videos how big this patient is, but I'll tell you they're pretty average size. So I'm going to start a little bit more lateral than what you see on the screen. So I'll just mark here, and I don't know if you can see. Yes, on the cameras you can see what I've done. And we're going to be doing an implant. So what I do is I generally use an 11 blade. In this case, we have a little 10, and we'll just do a 1 centimeter incision. And then we've got our 14 gauge 2E, which is, again, pretty similar to what you guys are accustomed to with SCS. And since I've drawn that line, I can just basically follow that out under fluoro. And I can go really shallow just to make sure everything looks good. And you can see I'm heading towards that lamina spinous process nook. And now what I'm doing is I'm diving my needle down, so I'm getting right on lamina. Okay, so imagine when you're flying home tomorrow or Sunday, how your airplane is landing, right? They fly in level, they kind of descend, and then they'll plateau, they'll descend, they'll plateau. That's exactly what I do with the 2E needle. So I'm really making sure I get down onto lamina now because I'm getting close to that interlaminar space. So if I need to back up and go steep, so now I'm hitting bone right here. Okay, and I say to myself, bone is home. I have my Zen moment, and then I walk off the lamina, and I just feel it advance. So again, my goal here is to get right into that midline epidural space, and I'm starting to feel it lose right there, okay? So I'll take my LOR syringe, wherever that might be, and we'll grab one here in just a second. And we can think about other ways of entering the epidural space, such as hanging drop or purely using fluoro. Lost a lead, but we found an LOR syringe, thankfully. And what I'll do is I'll just advance until we get that nice loss. And you start to worry, like, gee, am I going too far across that midline, right, as I enter here? So if that is the case, maybe I need to back up. I think we're okay here, so if I'll really steepen up to really enter, because I really want to enter pretty fast here. And what I do is a little rotation of my needle to sort of get it across that flavum. That wasn't the clearest loss, but we'll take a look. And yeah, we'll take that. So if I'm in the zone of the spinous process, I'm happy. What I'm going to do is just check. You know, these cadavers, these LORs are pretty suspect, so we'll just check with a little guide wire to see if I'm in the epidural space. And if that goes out, yeah, that looks good. And look what the guide wire wanted to do. It wanted to stay in the posterior midline of the epidural space. That's the path of least resistance. Now what we're going to do, which camera should I look at, Tyler?
I think this one. Right in
Perfect.
front of you.
So what I'm going to show you here is the sheath. It's loaded up with a lead and a stylet, which is this green wire. Usually it's not curved like this, but nonetheless for this it is. And what we've done is we've locked it so that the lead is inside the sheath with the little nubbin sticking out.
Right.
Yeah, you got it. So there's a little nubbin sticking out. And the reason why this is important is if my lead is retracted a little bit, so I'll show you that. I don't know how much detail you have on the camera. If I try to plow this through the epidural space, it's basically an anteater nose, right? Trying to go through, and it's going to meet all this resistance because there's basically a hollow tube trying to go through epidural fat. If I advance my lead out too far, well, now this lead is all flimsy, just dinging and hitting the bone spurs and the epidural fat. So you really need to find that sweet spot where to create the most aerodynamic look to the sheath and lead complex, there's just a nub, which is a very technical term for what you're seeing here. What does this look like under fluoro? So what I'm going to do is you hold the needle, you advance that curved sheath. The white dot on the sheath is indicating when you're getting into the epidural space. So we'll take a look here. And you can see what you already see is that the sheath and the distal electrode, number one, is, let me just pull this. Do you guys mind getting a straight stylet? Because this keeps on hooking me in the back.
Yes.
Thanks. So we're just going to get a new stylet because it keeps on latching onto me when I'm trying to, it really likes me. All right, and I think my needle's pulled back a little bit, so I'm just going to advance a wee bit. And as Jen said, what she does is she drops the angle as she advances a little bit, so again, that's a wise move. There we go. Let's see if we're too far across. No, we're okay. Okay, so we only have a curved stylet, but let's see where we've lost our LOR location here. So let me come back and just go a little bit more steep with the LOR. Seems pretty clear there. And then we'll take the guide wire. And there was that conversation about LOR to saline versus LOR to air. When we teach you guys in residency and fellowship, let's do 45 degrees contralateral oblique and just see where we are. Victor, if you don't mind. So I towards you, 45 degrees.
45 degrees.
Yep. The reason we train you guys to use saline is because there's always a concern about pneumocephalus, especially if you're doing a perioperative epidural. But in interventional pain, frankly, the reason I don't like to use saline is because if there's a pressurized epidural space, especially in a degenerated spine, is it CSF or is it saline? So I always use air, but when I get my loss, I just feel it and I'm done. I'm not pushing 5 or 10 cc's of air. So I think the subtlety is you can use air, just feel the loss and be done. Don't inject air. Go ahead, guys. Let's see what we got here at 45 degrees. So yeah, I'm a little bit out, as you can see here, because I pulled back just because I just don't want to advance. And shot there. And I'm just getting to that laminar line. And I'm just using the fluoro here to identify shot there, because again, you never know with these cadavers how this looks. And let's see if I can get this guide wire in here. Very common at lower levels to deal with more of the fibrosis. I'm gonna go a little bit more steep shot there, Victor. Yeah, it should be in, but again, there's a bit of resistance, so we'll see how this looks. Shot there. So I'm meeting a little bit of resistance. Let's come around to AP. Let's see what we're hitting here. Yeah. So if I have a perfectly midline chewy needle, and you see that spinal that laminar line, I really should be, in. My LOR is certainly indicating as such. So now you just wonder, am I in the epidural space, but there's just some resistance from other issues? I'll just, again, for curiosity, do loss to lead here and see if I advance a little bit, if I get a little bit more of a smooth. No, resistance there. And I do think at this point, given my depth from fluoro, that there is something impeding us here. So let's go full lateral, just make sure we are where we are. And this happens certainly more so in DRG simulation because we're working with lower levels where you tend to see more degeneration of the spine, and you can see some of the osteophytes already on this cadaver. It can happen in spinal cord stimulation, especially, yeah, so I'm still out quite a bit based on that, so forgive me on that. I'm getting some false losses. And the issue is I need to back up and go more steep because shot there. Perfect, so I should be there now. And there we go, shot there. All right, a little troubleshooting. Let's come around to AP. So it's getting some false losses. That's okay, that happens with these cadavers. Now the question is, all right, I'm in, but am I too far across midline? I certainly could be at this point because I advanced, shot here. And we're just a bit more lateral than I'd want to be. So I am going to back it up and come down a little bit more steep. Shot there. And do you mind giving more clearance, Victor, here for the LOR? Thank you, sir. Okay, let's see if that works. Shot there. Beautiful. So I love that. Let's see if this is the right plane of loss of resistance. Looks like it. Shot there. Joy. So that is going right towards that pedicle, as you can see if we drew that line out. And now I've got my nubbin screwed on tight. And notice my bevel is this black line. Can you see that on the camera? There's a black line. That means my bevel is up. My flush port and my bevel are all facing the same direction, okay? And shot there. Okay, I'm looking over here. And shot there. Getting a little resistance again. And the guide wire is a little bit more stiff than the sheath lead complex. So let's go lateral again, just to really make sure we're in the right spot, and then I'm right at midline. I may need to advance, but I don't want to just start advancing willy-nilly, because obviously the only thing you can do to screw this up is get into the thecal sac. So always good to be more cautious in these situations. Just check where you are. Yeah, just a little bit. I can certainly advance. There we go. And there is quite a bit of schmutz in there. I can feel it. Shot there. Good. And then we'll go around to AP. So again, just some safety checks. It's always good to be a little bit more cautious than aggressive, even though I am timed to 30 minutes to finish this whole thing. Cool. So that looks good. And now, Victor, if you can collimate over that right L3 pedicle. So my hands are out of the way. So circle collimate, please. Iris. Circle collimate, not shutters collimate. No problem. Bit more. Okay, cool. So now the reason for all that is because I'm going to be doing live fluoro, and I'm going to start excavating laterally. What you can notice on the camera view of my hands is that I'm rotating a little bit more lateral. There we go. You see that? And I'm coming out of the foramen. This is that resistance, and I'm just punching. Couple options here. One is just to hold pressure. Another option is a punch out. What I notice is my lead's a little bit retracted. So I just pulled back my sheath so that contact 1 and the sheath tip are overlapping. This is what it looks like under live, and when I'm punching, this is where the patients go, oh, I really feel that. That's okay. Everything will be fine. So my lead retracted a little bit. Just means the screw mechanism isn't as tight as we like. That's okay. I'll pull back a little bit. And I'll make this super tight. You really can't over-screw it. So that will do that. And we just work on this. And you just never know how tight these ligaments are, especially since I didn't do any preoperative workup or anything like that, or how cold this cadaver is. And if that doesn't work, what we can do is take the guide wire, put it through the sheath, which is providing a bit more rigidity. And we'll do that here. And some people prefer to just go out with the guide wire, and that's totally fine. I always just try to do the least, that you can, meaning that if I just get my lead out, then I'm done. I don't have to bother with switching it out. So just curiously, I'll just see what happens if I just push the guide wire out. Oh, that looks awesome. And then I can just bring my sheath out over it, follow out. So I'm just doing a little tapping. I think we're getting far enough here. Perfect. I'll bring that back, and then I'll advance a little bit more. Yeah, I think we're good there. So then, in order to prevent this from collapsing down, I like to have my lead ready to go, styletted. And then this is always the fun part, is making sure this does not have a stylet in. That's the issue with the curved stylet.
Just one. This thing is hanging over you.
Yep.
So,
We don't typically have curved stylets because of that reason.
so Ramo,
Yeah,
question.
please.
So you're using the guide wire to advance lead a little further into the framing?
Yep.
So I don't be clear, that's all.
Perfect. And right now I'm meeting a little bit of resistance.
There we go.
Which there typically isn't, but nonetheless, let's get that guide wire again, make sure the stylet doesn't come out. Let me try that. This is definitely a therapy where you have to have a plan A through G. You'll see lots of different stuff, so it's good to see people like me struggle. So I'm pulling back the sheet, there we go. There's a little bit of a potential kink in the sheet. I don't know if these are used or not, but so I just can't advance out. It's okay. So what I'm going to do is just take this all out and take a look at what the issue might be. And there is indeed a little distal kink in the sheet, so we're going to get a new one and load this up. And now that I've already created that track, it should be easier.
Is that pretty common to have a kink in the sheath?
Yeah, I don't know if I caused that or if that was just because these have been used. I have no idea. Certainly these stylets have been used because they have this fish hook on it, which is catching my yellow gown, which is fun. But usually those are straight, and they shouldn't be catching on anything. So I think tomorrow in the lab we'll hopefully have straight ones here.
Robert, can you show the audience the kink in the sheath there?
Yeah, we'll grab that here for you. Did you already toss it? Okay. Yeah, we already tossed it because we wanted to make sure it didn't show up in the mix. Sorry. Maybe we can still grab it though. There we go.
This is good because this is real world troubleshooting, you know.
That's right. That's
some
why
of the things
these
you guys
guys
know
always give me
about.
the DRG one. Okay. So a bit low in the pedicle, coming out. Now the question is, can I find the same hole that I had before? There we go. I'm out, so 2 and 3 are out. Yay. All right, so now what I do is I pull back the stylet just a couple inches. I unscrew. Take a deep breath, and we'll check a lateral here, Victor, just to see what we're looking like.
That looks great.
And then what I'm going to have happen is Kasim is going to do the same thing. Beautiful. So you guys can see it's in the neuroforamen, high and tight, and back over to AP with that same collimated look over the L3 pedicle. And it's posterior to the posterior wall of the vertebral body. Okay, so that's the key thing here. We're not going for the VRG or the ventral. I'm joking. There is no VRG. We're staying at the DRG, the dorsal root ganglion. So now we're just going to put everything back in, screw it, replace the stylet. And I want Hasim to experience the joys of placing. Okay, so yeah, you'll put your left hand on the 2E needle.
Rama, can we get back to that lateral as well? Just to outline for the audience.
Can you guys put up
where exactly you want?
We'll show you again.
Okay, thank you.
Now we'll have Hasim have his. So you're gonna use the pedal, and you're gonna just use live, and Victor put it on pulsed for you to reduce your radiation exposure. That's great. So just do it under live, not under intermittent, under live. You want to see what's happening, and then careful, the sheath will kink or bend. The next generation of sheath is going to be more resistant to this. But once it kinks, guys, you have to start over because what happens is the lead is unable to advance or pull back. So we may need to get another set of new sheets because that degree of curving is really something you shouldn't see.
Yes.
It's really got to be much more gentle because once, again, that tube cracks down, that looks better. So you're really aiming out towards the foramen. That's great. And you'll do some little punches. Thank you, sir. Do you mind loading this up with the new lead-ins? Yeah. And as you can see here, it's not easy because, again, you're going through fibrosis, osteophytes underneath that pedicle from the facet joints. And then what you're trying to do now is he's hitting the ligaments, so that's why it's bowing down.
Yeah.
So you have to hit it a little bit more, and we'll take a look here at this looks good. So he's got the bevel and the flush port perfectly together. This looks great. So just keep on punching, holding the needle with your left hand. Yes. And then exactly, your right hand is right at the base. Let's column it a bit more, Victor, so his hand doesn't get radiated. This looks great. So what you can do is back up and punch under live. Let's just see what it looks like. Yeah. Yep. That looks great. So this is the part where we're feeling the ligaments, the patient's feeling ligament. You're almost there. What you want to make sure you don't do, though, is kink that sheet. So it's a very delicate balance of trying to push it out. That's great. Yes.
Okay, it's not.
You're almost there. So you can pull it back a little bit further, yeah, and then get a little higher up into the pedicle. So you can aim flush port up now, flush port up, and yeah, and now yes. Now Hasim is getting higher into the neuroforamen underneath that pedicle. Yes, and he's getting a little bit further. Contact 2 is now sitting underneath the pedicle, and if we can just get that little loss right here, he'll be in good shape. And this is real-world stuff, guys. This is why DRG simulate. And so right there, I don't know if you noticed, it kinked.
Yeah, big kink. Yeah.
Okay, so that means we're done with this sheet
With this
lead system. Yeah, because now if you even get the lead to where you want, you won't be able to retract the sheath because there's now a bend in the sheath. Yeah, and those electrodes will get caught on the kink. So you have to leave the needle in place, and then we'll take out the sheath lead complex. And then for the purposes of time, David, did we get a new one? Perfect. Do you want to load that up for us so we're ready to go? So what I'll do is we'll just get a new sheath, new lead, a stylet. We'll get that out. We'll take a look at that lateral, Glenn, and then we'll flip to doing the tension relief loops and the IPG placement.
Sounds good.
Not quite yet. So I'm going to get this out. Perfect, and just a nub. I can do all that. Perfect, thank you, sir. Perfect. I mean, a Wisconsin Badger can do this. I said a Wisconsin Badger can do this. I heard some Big Ten talk going on out there, so I had to just chime in. All right, cool. So, Kasim, great job, my friend. We'll just see where we're at now as far as the epidural space. I think we're a little bit back. And this is very common for the needle to move during all of this because you're really manipulating it. So sometimes it pulls back, sometimes it pulls forward. So again, why don't we go back to that lateral here? Let's just see where we are again. Again, always better to be safe than sorry. So I don't know after the last manipulation where we are, so I'm just going to pull back a little bit, making sure we're okay. Okay, and then take off the mag, Victor, so we can see the shot there. And then raise up C-arm or take off the collimation. Yep, perfect. So let's get a loss to lead here. This is a technique you can employ for SCS as well. Boy, that already looks money. Sweet. Let's go back. Let me just make sure I can get this in, actually. So where was the kinked one?
Yep, this is the one you.
This is the kinked one? No, I don't think so. Let's.
No, this is.
Yeah, this is the kinked one. Okay. So we take that kinked one and we get rid of it because this can also happen on the field. Yep, I'm aware. Thank you, sir. Okay, so let's go back to AP here. Perfect. Column 8 over L3 here, Victor. Yep. What's that? Yep, circle one. Yep. A little bit more. Mag 1, so my hand's out of the way. Yep. Yeah, please. Which way am I looking? Yep. So Victor and I are working together for the first time. Obviously, you'll develop a relationship with your fluorotech on, how to do things. But yeah, this is one where that relationship has to be really sound and perfect. So I'm rotating over. Getting to that pedicle now. And it's not easy here, but we're getting there. Too low. So what we're seeing here is there's a plane of the epidural space that was met.
There, yes, something's.
And we're just hitting some of that same stuff. We'll do guide wire again. And we'll lock here. And collimate a bit more here. Victor, that comes out. Collimate more, please. We'll get that. This curve stylet keeps on wanting to hug me. And then we'll put that in. So it's not quite coming out as far as we want, but I'll just push the lead out. And now, let's take a look at a lateral. So Glenn, this is that shot you wanted to see as far as where the electrodes should be. They should be posterior to the posterior border of the vertebral body. So if Doug or Glenn, if you're in the classroom, can point out that line. So you can see that vertebral block, the rectangle, the line on the left-hand side of it is where you need to be behind or left of. So this is perfect. We'll come back around, Victor.
Okay.
So stylet is out, and I'm already going to, just for purposes of time, just start to pull back on the sheath. Oh. Unfortunately, I think, guys, I got a kinker because you guys can see how when I'm trying to bring back the sheath, the lead also wants to come back. Oh, there we go. Just got through it, which we'll take. And now what I'm going to do is rotate my flush port and needle towards the 12 o'clock position. That raises up the lead. And now I'm going to try to create this cephalad loop. We'll see how this goes. Bringing back the sheath to the midline. Boom, and it pops. Now I'll just try to advance lead. Create the cephalad loop here, get it up to the top of that vertebral body, bring the sheath in a bit more. Then I'm going to rotate everything over to that 4 o'clock position. I'm going to advance lead if I can. Sometimes you have to drive it out there rather than just depend on the lead itself. And meeting a bit of resistance there. So the needle's retracted a little bit, so I'm going to advance it. Okay, and I rotate all this over to 4 o'clock. There we go. And now I'm creating that cephalad loop. And that looks great. And then I can rotate all this over to the left. and create that little S here. So a little overlap there, but we're happy with that. I've got 5 minutes to tunnel this over. So what I do now, per Doug's lead, because he wanted to show this, I bring the needle back to the sheath, and then we'll just take a shot there. You can see I probably advanced everything. That's okay, just like you saw with SCS and Gen. If you advance things a bit more, that's totally fine, because you can always pull back. Oh, no pressure there. Yeah, you want that to come out. And I'm just feeding lead as I go. You get to this point here where you can't really grab on, and then you grab on, and then the stylet comes out. We take a look. So lots of jumbled lead, but guess what? I can always take that out. Oh, that's nice. So I got my S loop. The patient told me they wanted their IPG right here. I said, I'm happy to do that for you. So we'll take a straight rule marking pen. And what I try to do is, if you guys see the interface between the metal and the header, that's usually about 4 centimeters for this particular company. That's the line I usually like to take. I follow longer lines as far as the patient's skin for cosmetic purposes and closure. So let's just arbitrarily go for a 4 centimeter point there. We'll see how that lines up. Perfect. You can go, of course, a little bit longer if you want, just to make it easier for you. Obviously, use local anesthetic. I use a 27 gauge. And then your blade, really firm pressure with traction. You know, that's the key thing here. Get down. And then usually I would use METs and electrocautery to get down. With these cadavers, though, I can use, perfect. You got it? Thank you, sir. So this is a curved scissors. So what we're doing here is I'm expanding, going down through scarpas into a distance of anywhere between 2 to 4 centimeters. It's important for you guys to know, am I working with a rechargeable IPG or a primary cell? Usually with the rechargeable IPGs, you're limited to going to 2 centimeters because it has to communicate. With the primary cells, you can go down to 4 centimeters, which is kind of more comfortable for the patient. So a little bit of dissection cephalad, a little bit of dissection caudal, and I can do some finger dissection here. And then I'll just see if the IPG will fit. Oh, that looks great. You can see I got a good closure there. And now what I'll do is I'll take my straw tunneling tool. You guys mind if I use this, or do you want me to use a TUI? Cool. So I'll curve this straw tunneling tool, if you guys can see this. I made that previous incision from the lead site. The recommendation now is to anchor a DRG lead. Historically, and many of us, not us, but people in Europe do not. And I used to not, but now the recommendation is to anchor here, so I would otherwise do that. But for the purposes of time in this demonstration, what I do is, can you clear the C-arm, Victor? Thank you, sir. So the straw tunneling tool needs to come up, have some depth. You can actually just move it completely. Perfect. And so I just go right next to that lead, and I'm feeling, and you guys can see it pop out here. Then I unscrew. 2 minutes to connect to my header. I'll take DeBakey's. Or a Raytech. Do you have a 4x4? Can you give me those 4x4s?
Hmm?
The 4x4s, the gauzes.
Gauze, okay.
No.
Which one? Oh, gauze, sorry.
No problem. So usually some friction there. I'll take the sponge clamp like you had, ring forceps. Yeah. Okay. Actually, I'll take this rongeur. We're ready for Shauner to get in here. So we'll just, MacGyver what we're doing, or MacGoober. Pull that. Got the straw through. Lead comes around through the straw. And you can see here, you'll feed it. Comes around. And then I'll line it up with the header. I'll say, David, I'm going to put this in port 1. And he says, that's great. That's the lower left one. Blue line's there. Torque wrench is right here. And so the screw port, or the torque wrench, enters for port 1 here. And you'll hear 2-3 clicks once it gets down. And we're checking impedances. And he's like, oh, yeah, that sounds awesome. You guys hear that? Click, click. Lots of clicks, however many clicks you want. That's great. And then in the other ports, we'll plug that so that, adipose or whatever else doesn't get in there. So So we'll plug those, screw those all down, and then I'll pull this through. I like to leave a little tension relief loop at the skin insertion site. So what I'll do here is I'll just bury this loop in that fascial plane that I make pre-op or at the start of the surgery. So that sits down. Then I'll take the rest of the lead. I'll wrap this behind the IPG. And then we'll insert like so. So the lead is behind the IPG. The lead should not be in front of, right? Because this is where the communication is going to go from to external, whether you're programming or recharging. So everything is behind. And now, Victor, come on in and take a shot of the IPG and the lead, magging out. And now you can see the entire system fluoroscopically with the S-curve going out. I think it's 10 o'clock. I think I did it, guys. What do you think?
Well, great job.
All right. So a little struggle up front, but we got the job done.
Awesome.
And then can you see the electrodes here, Victor? Drop the II. Yep, mag out as much as possible. I think you have mag on still. So you got the electrodes out there, and you can see it going out towards the iliac crest and the IPG site. So we'll open everything up. And there you go.
Nice. Well, excellent. So for the
Any
audience,
questions from
any questions for the fellows or audience?